Anticonvulsant, and I am with my pair, which is Isaiah Pepito. So, moving on, let's talk about anticonvulsants. So, to begin with, anticonvulsant, anti-epileptic, or anti-seizure drugs, these are medications used to treat seizure disorders and help suppress seizures. And also, epilepsy is the most prevalent neurological disorder affecting more than 0.5% of the world's population, in which it is usually characterized by recurrent seizures and um, due to unprovoked thing, in which the etiology of epilepsy is largely unknown. And seizures are these are symptoms of disturbed electrical activity in the brain, characterized by episodes of abnormal, excessive, and synchronous discharge of a group of neurons within the brain that causes involuntary movement, sensation, or thought. So usually epilepsy is being described as the sudden burst of uncontrolled electrical activity in the brain that occurs when neurons become excessively active. And usually, seizures happen when it is the result of an imbalance between the inhibitory and excitatory processes in the brain, that it's either produces too much glutamate or too little um, I sorry, too little inhibition and too much excitation. Okay, so there. And the commonly used anti-epileptic drugs are valproic acid, carbamazepine, ethosuximide, and phenytoin or phenytoin to prevent recurrence of seizure activity. So it has been stated here that one-third of the newly diagnosed patients become resistant to current pharmacotherapy. It is due to the reason that there's a prolonged drug exposure, and the tendency of it is that it will um, decrease or it will lessen the effectiveness of the said drug products. And then seizures are classified based on their initial signs and symptoms and the pattern seen on the electroencephalogram into two broad categories, as generalized seizures or as partial seizures. So I would like to apologize if I wasn't able to include here the result or the pattern that can be seen or the pattern that can be reflected in the electroencephalogram. And each of the epilepsy types is characterized by an abnormal pattern in the EEG, and the EEG indicates the sudden, excessive electrical activity in the brain, wherein the generalized seizures or the partial seizures have their own unique and corresponding abnormal patterns. So now let's proceed to the classification of epileptic seizures. So we have two major types of epileptic seizures. We have the generalized seizure and the partial seizure. So let's begin with the generalized seizure. So in our reference book, we only have two. It's stated there that there's only the tonic-clonic seizure or the grand mal and the absence seizure or the petit mal. However, I've find or I've searched for any other references, so I made a cross reference, and I found out that there are also four more types of general seizure, which includes the myoclonic, clonic, tonic, and atonic. So now, let's move on to the generalized seizure. So first would be the generalized seizure may begin locally, and then they usually progress to include abnormal electrical discharges throughout both hemispheres of the brain. So we all know that we have two hemispheres of the brain, the left and the right, and they have and in that hemispheres they have their own corresponding lobes. And the primary generalized seizures may be convulsive or non-convulsive, and the patient usually has an immediate loss of consciousness. So now let's proceed to the types of general seizures. So let's begin with the tonic-clonic or the grand mal. So the tonic-clonic or the grand mal is also known, or you can also call them the convulsive seizures, in which these seizures result in a loss of consciousness, which is usually followed by tonic and clonic phases. So when we say tonic, there's a continuous contraction And when we say clonic phases, there's a rapid contraction and relaxation afterwards. So the seizure may be followed by a period of confusion and exhaustion due to the depletion of glucose and energy stores. So when the patient or when a person undergone or experience tonic-clonic or grand mal seizure, then it puts or it places our body in a huge amount of stress, and that is why there is an oxygen and glucose depletion and also our energy. And when that happens, there's an accumulation of lactic acid as the byproduct of the muscle activity. And then there it puts our body in a huge amount of stress, so the demand for the oxygen and for the glucose skyrockets or it increases. So that usually happens in the tonic-clonic seizure. So as you can see here, um, there for the picture, you have the tonic phase. So there is the contraction, and then you have here the clonic phase. So you have there the corresponding um, episodes, or what are the symptoms or what are the signs that you will be able to observe during this stage, and of course the post-ictal confusional fatigue. Let's not really dwell more on that. Now let's move on to the absence or the Fatima seizures. So when we talk about absence, usually this type of seizure is mistakenly to be a simple daydreaming. So these seizures involve a brief, abrupt, and self-limiting loss of consciousness in which the patient stops and then they stare for about 15 seconds or less. And then after that, they will exhibit a rapid eye blinking that usually lasts for 3 to 5 seconds. So when you observe a patient um, doing a rapid blinking of the eye, then automatically the patient is experiencing the absence seizure. Now, for the myoclonic, so these seizures consist of short episodes of muscle contractions that may recur for several minutes, and they generally occur after awakening and exhibit as brief jerks of the limbs. And this usually begin around puberty or childhood. So for the myoclonic, this is often characterized by a sudden body jolts or increase of muscle tone, and as if the person is experiencing or had been jolted with electricity. So usually for the myoclonic type of seizure, it really starts in our limbs here. So as you can see in the picture that um, the person just like doing this thing, just being jolted, like um, feels like marsyag na kuryentehan. So that's the episode of myoclonic seizures. And myoclonic seizures usually begin around puberty or adulthood. So that's what I have mentioned earlier. Okay. So moving on to the next three types of generalized seizures, we have the clonic. So these seizures consist of short episodes of muscle contractions that may closely resemble myoclonic seizures. So when we say clonic phase, there is a muscle contraction, there is jerking, and however, usually clonic and myoclonic are being used interchangeably, or they may resemble with their signs and symptoms. However, the clonic phase is that the consciousness, the consciousness is more impaired compared to your myoclonic, and there's a jerking motion that slows down as the seizure subsides. So as the jerking stops, for the person, common response of a person after that um, jerking is that the person would let out a deep sigh before resuming normal breathing. So when you hear a person after this phase or after this seizure, when you hear a person do the deep sigh thing, then the person is obviously experiencing clonic seizure. Okay, for the tonic phase, For the tonic seizure rather, these seizures involve increased tone in the extension muscles and are generally less than 60 seconds long. So, what you can observe when you say clonic, so you can observe abnormal movements. But when you say tonic, the person's muscles stiffen or there's a stretching. So as you can see in the picture that um, the body of the person kay more siyang nilay down then more ni straighten ang iyang body. So it stretches or the person's muscle stiffens. And lastly, for the last type of general seizure would be the atonic. So these seizures are also known as the drop attacks. So there's no other type of seizures that would be called drop attacks other than atonic. And these are characterized by a sudden loss of muscle tone. So of course, when there's a sudden loss of muscle tone, then the person would experience going limp, slump, or collapse, and possibly they may be experiencing or they may be causing themselves an injury. And then let's move on. Let's move on to the recommended initial monotherapy. So for the clonic seizure, the patient can take carbamazepine, oxcarbazepine, lamotrigine, valproic acid, phenytoin, topiramate. And for the absence seizure for the children, they can or we can administer uh, or we can let our patient take lamotrigine, valproic acid, or ethosuximide. Sorry. Now, let's proceed to the partial seizure. So, partial seizures involve only one portion of the brain. So, a while ago, um, generalized seizures affects both hemispheres of the brain. Now, for the partial seizures, it only involves one portion of the brain, in which typically part of one lobe of one hemisphere. The symptoms of each seizure type depend on the site of neuronal discharge and on the extent to which the electrical activity spreads to other neurons in the brain. Focal or partial seizures may progress to become generalized tonic-clonic seizures. So for the partial seizures later on, there are two types rather. We have the simple partial seizure, also known as the focal seizure, and the complex partial seizures. So for the complex partial seizures later on, um, just to give a heads up, is that it usually affects the temporal lobe or the psychomotor. So when it affects the temporal lobe is responsible man for processing our memories that is usually associated or related to our senses, sense of taste, sense of touch, sense of hearing, and the other types of senses. So that's why later on you will notice that the what do you call the memory of the patient, there's an impairment of the memory of the patient or of the person undergoing a seizure. Okay, so here, simple partial seizure. These seizures are caused by a group of hyperactive neurons exhibiting abnormal electrical activity and are confined to a single locus in the brain. So when we talk about simple partial seizures, the patient does not lose consciousness or awareness, and the patient exhibits abnormal activity of a single limb or muscle group that is controlled by the region of the brain experiencing the disturbance. And for the simple partial seizure, there's this Jacksonian motor epilepsy in which the Jacksonian march may be seen. So Jacksonian march or Jacksonian epilepsy, this means that there's the spread of the seizures from a initial point down to the uh, down to the whole brain. So it just simply means that it's, let's say, for example, it starts from the limbs and then eventually it will progress or it will develop or the seizure will develop into the whole body of the patient. So usually the drugs that are given to this type of seizure would be carbamazepine or phenytoin for adults, lamotrigine or gabapentin for elderly adults, and oxcarbazepine for children. Now, for complex partial seizures, these seizures exhibit complex sensory hallucinations and mental distortion. So there's an aura. So when we say about aura, so meaning there's an altered vision, and there's also an inability to speak like directly or just speak. There's an impairment sa speaking. So then a confused, bizarre, but seemingly purposeful behavior lasting for 2 to 3 minutes, often with no memory of the event. So a while ago, this what I have mentioned, that a complex partial seizure, kay it affects man the temporal lobe. So temporal lobe is responsible for processing our memories. So that's why here, the patient will not have any idea, or will not have any memory about the seizure episodes or the event that had happened to her or him prior to kanang or after the seizure. So he or she will not have any knowledge that um, there's a seizure activity that had happened. So there's also a motor dysfunction that may involve chewing movements, diarrhea, and or urination, and the consciousness also is altered. So now, anticonvulsants used in neuropathic pain. So they are characterized by a neuronal hyperexcitability in damaged areas of the nerves. And anticonvulsants such as carbamazepine and gabapentin are recently its close analog. So pregabalin were approved for relieving pains associated with diabetic neuropathy. So diabetic neuropathy is the nerve damage due to diabetes, wherein high blood sugar can injure the nerves throughout our body. And then for the trigeminal neuralgia, this is a chronic condition in which it affects our trigeminal nerve, which carries the sensation from our face to our brain. So, usually, when we say about, or when a person is having this trigeminal neuralgia, let's say, for example, he or she is brushing his or her teeth, or putting some makeup, then just a simple or mild stimulation in the face, it will now cause an excessive pain, or it will now trigger a jolt of excruciating pain to the patient, and also other neuropathic pains. Now, let's proceed to the MOA, or the mechanism of action of anticonvulsants. So we only have three basic mechanisms of anticonvulsants. First, we have the modulation of voltage-gated ion channels, sodium, calcium, and potassium. And then we also have the enhancement of gamma-aminobutyric acid, or the GABA-mediated inhibitory neurotransmission, and the attenuation of excitatory, particularly the glutamate-mediated neurotransmission in the brain. So just to give a heads up, the inhibitory neurotransmitter responsible for the inhibition would be the glutamate. I would be the GABA rather, sorry. And then for the excitation neurotransmitter, or excitatory neurotransmitter responsible for the excitation, would be the glutamate. Okay. So now, let's discuss about the voltage-gated ion channels as targets for anticonvulsants. So we have three: voltage-gated sodium channel, voltage-gated calcium channel, and voltage-gated potassium channel. Okay. So first would be the main form of communication among neurons occurs through the traveling wave of electrical excitation known as action potential. So an action potential happens when there's a synchronized opening and closing of our voltage gated ion channels. So in this part, we have the sodium, the calcium, and the potassium. So simple excitatory neurons, when they are at rest inside, they are slightly negative compared, or slightly more negative compared to your outside of the neuron. So an action potential usually starts when the voltage-gated sodium channel opens, allowing the entry of the positively charged sodium ions. Thus, it will reverse the polarization of the membrane. So just come to think of it, that the inside of the neuron of the membrane is negative, and then the outside would be positive. So when the sodium voltage gated ion channels will open and will allow the entry of the sodium um, positively charged sodium ions, there will be now a polarization. So the positive ions will meaning it will switch back. So positive, the inside of the neuron or the membrane will become positive and the outside will become negative. But consequently, membrane depolarization leads to opening of high voltage activated calcium channels, which then allow positively charged um, calcium ions to enter neurons. Thereby, it will trigger the production or the release of the glutamate to from the vesicles into our synaptic cleft. So now after that, the glutamate will bind to the two types of receptor that comes from the postsynaptic neurons. We have the NMDA receptors and also the AMPA receptors. So AMPA receptors, also known as alpha amino 3 hydroxy 5 methyl 4 isoxazole propionic acid, and that upon binding of the glutamate to this kind of receptor, it will allow or it will open and will permit the entry of the sodium or yeah the sodium ions, and similar to the NMDA receptor or the N-methyl D-aspartate receptors, when the glutamate binds to it, then it will allow or it will permit the entry of the um, calcium ions. So in addition to that, calcium may enter through low voltage activated calcium channels, also known as the T-type calcium channels, and which open in response to small depolarizations at or below resting the membrane potential. So all this influx of positive ions would lead to depolarization and propagation of action potential. So just uh, put this in mind that if there is too much glutamate around neurons, it can become hyperexcitable, and this will now result or this will now cause seizures. However, later on, it will be discussed that we also have inhibitory neurons um, and that put brakes on the excitatory impulses. So the inhibitory neurons also release neurotransmitter GABA, which binds to your GABA A receptors on the excitatory neurons that would cause them to open and allow negatively charged chloride ions to enter in. So later on, it will be furtherly elaborated by my partner. So that would be all for the voltage gated ion channels. So just similar to the two, so that's what also happens for our voltage gated potassium channel. Now, for the GABA A receptors as targets for anticonvulsants, so it is now well recognized that cellular excitability leading to convulsive seizures can be attenuated by GABAergic stimulation in the brain. So the potential targets for a alpha anti-epileptic drugs action on the GABAergic inhibitor synapses include these four. So we have the drugs that enhance the biosynthesis of GABA. You have there the gabapentin, pregabalin, and the valproic acid. Drugs that inhibit GABA degradation, the vigabatrin. There are drugs that inhibit the uptake of the GABA, which is the tiagabine, and drugs that bind to an allosteric site of the postsynaptic GABA A receptor complex that would increase chloride conductance. We have there the barbiturates, the benzodiazepines, and neurosteroids, felbamate and topiramate. So now I will give the floor to my partner to discuss the additional uh, action of our topic for today. So
So
let's give it
next
up for
is
Isaiah.
drugs that enhance biosynthesis of GABA. So this is how GABA is produced. So GABA is an amino acid and it acts primarily as an inhibitory neurotransmitter. It interacts with the receptors of the neuron. It generally makes the neuron less likely to fire an action potential. So your GABA plays a vital role in relation with epilepsy because epileptic patient with low levels of GABA seizure will probably occur. So, and GABA is synthesized in the cytoplasm of the presynaptic neuron. So first is your GABA, the major inhibitory neurotransmitter in the brain, is biosynthesized at the GABAergic neurons. These are neurons responsible for producing GABA by the decarboxylation of the amino acid. So it removes the carboxyl group and releases carbon dioxide, as you can see from this picture, of the amino acid L-glutamic acid. Next is the enzyme responsible for converting L-glutamic acid to GABA is the glutamic acid decarboxylase, or your GAD. With vitamin B6 in the book called pyridoxal phosphate, it is a phosphorylated form, vitamin B6. So vitamin B6 is a catalyst, which means it's a substance that increases the rate of a chemical reaction in producing more GABA. So lack of vitamin B6 diet in epileptic patient is being recognized the cause of seizures, and most reported cases of this condition are in neonates but few adult cases. So increasing vitamin B6 diet might be a good help for patient with epilepsy. Next is GABA. After it released from the synaptic nerve terminal is degraded by another pyridoxal dependent enzyme, the GABA transaminase or GABA T, which transfers an amino group from GABA to a ketoglutarate producing L-glutamic acid again and succinic acid semialdehyde. Then succinic acid semialdehyde is further oxidized by the action of the enzyme succinic semialdehyde dehydrogenase and aldehyde dehydrogenase to succinic acid that can enter the TCA cycle for the production of additional alpha ketoglutarate or be further reduced by SSA reductase, an alcohol dehydrogenase that catalyzes the interconversion of SSA and 4-hydroxybutyric acid. Next slide, please. Next is, these are the drugs that enhance the biosynthesis of GABA. Being a three-substituted GABA, your gabapentin and pregabalin is an analog of GABA. So they have the same structure, but atoms have been replaced with, with a different atom or with a different functional group. Its mechanism of action is to activate GAD or the glutamic acid decarboxylase, in addition to the major anticonvulsant action at the high threshold L-type calcium channels in the presynaptic glutamatergic receptor. So activating GAD, your glutamic acid decarboxylase enzyme, converts L-glutamic acid to GABA, so there will be increased production of GABA, and it elevates brain GABA levels 75 to 100% in patients with epilepsy within hour after the first dosing. So increased GABA levels, it inhibits neuronal signals networks or makes the neuron less likely to fire an action potential, or hyperpolarization will occur, and hence avoiding seizure. So indications of these two, your gabapentin, it is approved as therapy for focal seizures and well tolerated by the elderly population with partial seizures due to its relatively mild adverse effects. So it may be also good choice for the older patient because there are few drug interactions. Your pregabalin, the exact role this drug plays in the treatment is not known, but the drug has proven effects on focal onset seizures, and it has no significant metabolism and few drug interactions. Next is your valproic acid. So your valproic acid also elevates brain levels of GABA in patients with epilepsy. So especially generalized and partial epilepsy. So it is generally agreed that valproic acid inhibits SSADH or succinic acid semialdehyde, the enzyme responsible for conversion to SSA to succinic acid. So, but the exact mechanism of action of valproic acid is the inhibition of GABA T, which enhances GABA levels in the brain, is still subject is still the subject of much debate because of its unknown action. So from an indirect stimulation of GAD to an inhibition of GABA T. So according to my research, it inhibits GABA T, especially high concentration of your valproic acid. Since it is the enzyme responsible for metabolizing GABA, so with less GABA can cause seizures. In epileptic patient, this drug, valproic acid, will inhibit or slow down GABA metabolism to succinic acid formaldehyde, therefore increase GABA levels, inhibit action potential or hyperpolarization, counteract seizure. And additional information, your valproic acid is available as a free acid. Divalproic sodium is a combination of sodium valproate and valproic acid that is converted to valproate when it reaches the gastrointestinal tract. So it was developed to improve gastrointestinal tolerance of valproic acid. Indication of valproic acid, it is effective for the treatment of focal and primary generalized epilepsies. And valproate also, it inhibits metabolism of the CYP9 enzyme. So we are expecting drug interactions with this drug. And additional information also, your valproic acid is a hazardous drug. It is carcinogenic, teratogenic, and genotoxic, and can cause organ toxicity at low dose, etc. And we must be careful or aware of it. Next slide. Next is the drugs that inhibit GABA degradation or metabolism. So your bigabatrin, briefly, your bigabatrin, because of its because of its structural similarity, competes with GABA for binding to GABA T and forms a SCIF-based intermediate with a cofactor pyridoxal phosphate similar to GABA. So mura siya mo compete sa GABA. So unlike its substrate GABA, during the process of transferring the amino group to the pyridoxal phosphate or being phosphorylated, a reactive intermediate is formed with bigabatrin that immediately attaches itself to the active site of the enzyme, therefore irreversibly inhibiting GABA T and transaminase and increasing GABA levels in the brain. So its mechanism of action is it will bind to the enzyme and stop breaking down GABA, provides more available GABA or elevates GABA levels, and inhibits or slows electrical signals. Hyperpolarization occur, therefore enhance avoiding seizures or producing anti-epileptic effect. So indication, your Sabril, it is a prescription medicine used with other treatments in adults refractory complex partial seizures. These are seizures that type of seizure that cannot be controlled even after he or she has tried several anti-epileptic medicines. Your Sabril is also available in a powder form. So powder form, we will mix it with water. This is used to control infantile spasms. This is a type of seizure that babies and children can have, especially 1 month to 2 years of age. So some drugs that may interact with this drug, especially retinotoxic drugs such as chloroquine, hydroxychloroquine, and phenothiazine. So we are expecting drug interactions. Next slide. Next is the drugs that inhibit reuptake of GABA. So when GABA dissociates from the GABA receptors in the second picture, it will be released in the synaptic cleft. So release GABA is actively taken back to the GABAergic neurons or glial cells in the presynaptic terminal or neuron in the brain by GABA transporters or GAT, and it will be degraded primarily by mitochondrial enzymes or GABA transaminase in the glial cell. So your thiagabine structurally related to nipicotic acid, which is the derivative of the thiagabine, the derivative of nipicotic acid. Its mechanism of action is it inhibits the neuronal and glial GAT1 transporters at the GABAergic neuron. So So it inhibits the reuptake of GABA so that GABA will not be metabolized. And an effective drug for treatment of patients with refractory epilepsy. So these are patients taking anti-epilepsy medicines are no longer controlling seizures because of the reuptake of GABA. Addition of two lipophilic heterocyclic rings to the nucleopetic acid moiety did not interfere with its ability to bind GAT1, but actually allows thiagabine to cross into the brain freely and also more selectively than nicopetic acid towards GAT1 transporter. So indication your thiagabine is effective as an adjunctive treatment in partial onset seizures, and your thiagabine should not be used for indication other than epilepsy and also have drug interactions. Next slide. The drugs that bind to the GABA-A receptor complex and modulate chloride influx. So GABA-A receptors, these receptors are ionotropic receptors. So when a drug binds to the GABA-A receptor, it causes the opening of an associated channel that is permeable to the negatively charged ion chloride. When negative chloride ions flow into the neuron, they hyperpolarize the membrane potential and it make less likely the neuron will fire an action potential. So your benzodiazepines, lorazepam, diazepam, clonazepam, and clobazepam are your benzodiazepines. The first two, your um, lorazepam and diazepam, these two are used especially in emergency seizures because of their quick onset of action. And your clonazepam and uh, clobazam may be described as adjunctive therapy for particular type of seizures, so they can be used together, clonazepam and clobazam. Your diazepam is also available for rectal administration to avoid or interrupt prolonged generalized tonic-clonic seizures when oral administration is not possible. So, many clinically useful antipsychotic hypnotic sedatives and some AED drugs such as benzodiazepines and barbiturates exert their pharmacological actions by interacting with discrete neuronal site on the GABA-A or benzodiazepine receptor chloride channel complex. So the GABA-A chloride ionoform is a glycoprotein pentamer that contains 2 beta, 2 alpha, and 1 delta subunit and is present throughout the mammalian brain. So the function of GABA-A receptor depends on which subunit. For example, alpha-1 subunits are required for hypnotic, amnesic, and anticonvulsant effects of benzodiazepines, whereas alpha-2 subunits are required for the anxiolytic and myorelaxant effects of benzodiazepines. Okay, so it binds to its specific subunits for its function. So the mechanism of action of your benzodiazepines, so when binding of benzodiazepines to its receptor site, it increases the affinity of GABA, leads to increased frequency of the channel, and in turn increase influx chloride ions in the postsynaptic cell, which it ultimates make, which it ultimates makes it difficult for any excitatory inputs or signals to cause an action potential, hence providing anti-epileptic effect. Your next is your topiramate, a broad spectrum antiepileptic drug, also binds and increases the frequency of chloride channel opening but at a different site than the benzodiazepines. So next is your barbiturates, your phenobarbital, secobarbital, and your primidone. So mechanism of action of barbiturates, instead of increasing ion channel frequency, they increase the ion channel opening. It holds the ion channel open continuously, so there will be calcium influx for a long period of time. Hence decrease excitatory neurotransmitters. Your primidone and phenobarbital, they have anticonvulsant property, and secobarbital according to my research, it was widely abused. So dili ato siya ginagamit. Your phenobarbital, it is used in long-term management of tonic-clonic seizures and used primarily in the treatment of status epilepticus. Status epilepticus is a continuous seizure lasting more than 30 minutes. So this is used when other agents fail, this is used when other agents fail. Your primidone is a product of phenobarbital. This will be discussed later. Next slide. Next is the excitatory glutamate mediated receptors as target for anticonvulsants. So glutamate is an amino glutamate for I will talk uh, about the glutamate first. It is amino acid that function as excitatory neurotransmitter. With so when it interacts with these receptors of a neuron, it makes that neuron more likely to fire an action potential. So the acidic amino acid L-glutamate and L-aspartate are the most important excitatory neurotransmitter in the brain, acting to two distinct families of glutamate receptors, the ligand-gated ionotropic receptors and the G-protein coupled metabotropic receptors. So the ligand-gated glutamate receptors such as N-methyl-D-aspartic acid or your NMDA, amino 3 hydroxyl 5 methyl 4-isosazole propionic acid AMPA receptors. So these are two glutamate receptors. So potential activation of these receptors is responsible for important functions in the brain, including long-term potentiation in memory acquisition and learning and some neurodegenerative disorders. So these receptors, your AMPA and NMDA, are potential therapeutic targets for epilepsy and other neurodegenerative disorders. So, mechanism of action of glutamate of these receptors and anticonvulsant drugs that act on the same receptor. First is your NMDA receptor. So, in the absence of drug felbamate, uh, glutamate is released into the synaptic cleft from a vesicle in the presynaptic neuron and bind to the glutamate site or glycine site of the NMDA receptor, causes an open of the ion channel leading to an influx of sodium calcium ions, causes depolarization. Therefore, increased action potential, so it might cause seizures. This will cause seizures seen in epilepsy. But the presence of drug felbamate, it will bind to the glycine site, closes the ion channel, stopping sodium from entering, result in the action potential or hyperpolarization, so avoiding seizure. Your felbamate indications, it can be employed to treat partial seizures, generalized seizures associated with Lennox-Gastaut syndrome. This is a refractory epilepsy seen in children. It has also drug interactions because it is an inhibitor of drugs metabolized by CYP2C19 and induces drugs metabolized by CYP3A4. Next is your AMPA and kainite receptor. So without the drug topiramate, there will be depolarization, same when glutamate bind to this receptor. But in the presence of topiramate, binds to this receptor, with causing the channel to open. So when glutamate is released from vesicle in the presynaptic neuron, travels into the synaptic cleft, it cannot bind to the site. It cannot bind to the glutamate site of the AMPA receptor because it is blocked by topiramate. Therefore, the action potential from the epileptic focus cannot advance stopping a seizure from developing. The topiramate has multiple mechanisms of action aside from acting in the glutamate receptors. It also blocks VGSC or your voltage-gated sodium channel, high voltage calcium currents, and it is effective for the use in partial and primary generalized epilepsy. Next slide. Next is your metabotropic glutamate receptors. On the other hand, modulate the release of glutamic acid, GABA, and other important neurotransmitters in the brain. Side effects. However, efforts in finding effective and safe NMDA antagonists have failed because of their toxicities and intolerable side effects. Like felbamate and topiramate, they have bad side effects or severe side effects that can lead to stopping the use of these two medications. Thus, these receptors are exciting new therapeutic targets for designing medications for pain, addiction, Parkinson's disease, schizophrenia, and other neurodegenerative disorders. Next slide. Next slide is the clinically important anticonvulsants. First is your valproic acid. Your valproic acid is an established anti-epileptic drug with a simple chemical structure but unusually broad spectrum of action, because it was discussed earlier that it inhibits SSDH and GABA T, so valproic acid action is not specific, but it is generally well tolerated, but its use is limited by two rare significant toxic side effects, which your hepatotoxicity and teratogenicity, that can be dose dependent or idiosyncratic in nature. Your BPA is also an inhibitor of the cytochrome P40 isozymes, mainly CYP2C9 and other enzymes. Thus, an increase in the plasma concentrations of other anti-epileptic drug such as your lamotrigine is to be expected after dosing with BPA. So, when these two medicines are taken together, your valproic acid and lamotrigine, your valproic acid may decrease the ability of the body to process lamotrigine properly. So blood levels of lamotrigine may increase and cause a life-threatening rush. So these two drugs should not be taken, or the dose should be adjusted. And the major metabolite of your the major urinary inactive metabolite is 2-propyl 3-keto pentanoic acid, your T-keto BPA, and an active metabolite, your E2 in BPA. So, and other minor metabolites identified are the hydroxylated or dehydrated products and 2-propyl glutaric acid. And the hepatotoxicity of BPA is most likely associated with 2,4-diene BPA and 4-epoxy BPA rather than the 4-in BPA. So it have three toxic metabolite, but the hepatotoxicity of BPA is likely associated with the first two. So these toxic metabolites may also react with the sulhydryl group or other nucleophiles on the cellular protein, so thereby forming covalently bonded bond happens. So this drug modified proteins in our body then elicit and become the target of an immune response, thereby producing the observed idiosyncratic allergic reactions in clinically susceptible patients. Next slide. Ay, wala din. Next is your phenytoin. Your phenytoin, it is used to protect against seizures by causing voltage-dependent block of voltage-gated sodium channels. So it is useful in generalized tonic-clonic and partial seizures. Your phenytoin is a 5,5-diphenylhydantoin, is a prime example of an effective anticonvulsant acting through its action at the VGSC. And phenytoin is structure is very similar to phenobarbital but lacks the dependence liability. So phenytoin is very good at treating and preventing seizures, but it has many drug interactions and some serious side effects compared to phenobarbital. Phenytoin is a very effective. However, the drug may be your phenytoin, it may be incompletely or erratically absorbed from sites of administration because of its very low water solubility. So for this reason, phosphonitoin, a product of phenytoin, was developed and marketed to avoid side effects of phenytoin such as vein irritation, tissue damage, and muscle necrosis. So associated with parenteral phenytoin administration. So they made a prodrug to cover up the toxicity of phenytoin, which is your phosphenytoin. So phosphenytoin is a drug of choice and a standard of care of IV and intramuscular administration of phenytoin. The disadvantage is that phosphenytoin is more expensive than phenytoin. So, hypersensitivity reaction of phenytoin. Hypersensitivity reactions to phenytoin and other aromatic anti-epileptic drug in susceptible individuals are believed to stem from the reactions of these reactive intermediates, your aryl oxide, catechol, or O-phenol, with hepatic enzymes or other cellular proteins forming covalently bonded. So they will modify our proteins which is targeted by our own immune response. Next is your phenobarbital and primidone. So these are barbiturates. This was discussed and their mechanism of action was discussed earlier. So, um, your primidone is metabolized by CYP2C9 or CYP2C19 to phenobarbital and phenylethyl manolamide. So both of these two have two both of these metabolites have anticonvulsant activity or property. Your primidone is a so actually primidone is a product converts into a phenobarbital inside our body after metabolism, and it has two metabolites after metabolism, which is the phenylethylmalonamide and phenobarbital. So the primidone is much less potent toxic than phenobarbital because most of the drug is rapidly degraded to the less potent metabolite PEMA. Next is your camazepine and oxcarbazepine. Your oxcarbazepine is also a product that is rapidly reduced to the 10-monohydroxy metabolite responsible for its anticonvulsant activity, and its mechanism of action is it blocks sodium channels, preventing the spread of the abnormal discharge, and it also thought to modulate calcium channels, so it is approved for use in adults and children with partial onset seizures. So that's for oxcarbazepine. Your carbazepine, it is a carboxamide is an iminostilbene derivative of tricyclic antidepressant. So the two phenyls substituted on the urea nitrogen fit the pharmacophore pattern suggested for binding to the VGSC. Like phenytoin, your carbamazepine is useful in generalized tonic, clonic, and partial seizures. The epoxide structure is the suspect in idiosyncratic reaction carbazepine may produce. For example, a plastic anemia. So oxcarbazepine is a newer anti-epileptic drug which is a product with similar mechanism of action to carbamazepine, except for its metabolic inactivation pathway. So they have different metabolic pathway. Your carbamazepine undergoes epoxide production, can cause toxic side effects before it metabolizes to its inactive form, while the oxcarbazepine converted to its active metabolite and then its inactive form. Thus, for this reason, oxcarbazepine is said to have much fewer hepatic and idiosyncratic side effects associated with carbamazepine. Next is your gabapentin and pregabalin. Uh, Gabapentin in addition to modulating calcium influx and stimulate GABA biosynthesis as discussed earlier, they also compete for the biosynthesis of L-glutamic acid because of their structural similarity to L-leucine. Your gabapentin and pregabalin have very little liability for causing base-to-base drug interaction, particularly when used in combination with other anti-epileptic drug because they are not metabolized in humans. However, there are some differences in their bioavailability. Unlike gabapentin, which exhibits 60% bioavailability when given in low doses, because of intestinal uptake by a saturable small neutral L amino acid transporter. So The absorption of the pregabalin is almost complete, 98%, and it exhibits an ideal linear pharmacokinetic profile. So pregabalin have higher bioavailability. So in difference of the bioavailability, it probably affect their pharmacodynamics and pharmacokinetics properties. For example, pregabalin have high bioavailability, so its absorption is better than gabapentin. So it is almost completely absorbed, while gabapentin is not. So the absorption of gabapentin is limited to the small intestine. Next is your felbamate and fluorofelbamate. Uh, your fluorofelbamate is another potent and effective anti-infective drug with a broad spectrum of action. Uh, and it is a carbamate ester of 2-phenyl 1,3-propanediol, structurally similar to antisylotic drug meprobamate. So the carbamate ester in the felbamate is stable to esterases, so it will not be easily be degraded and therefore provides good oral bioavailability. However, the felbamate therapy was found to be associated with rare but severe side effects such as aplastic anemia, idiosyncratic reactions, and hepatic failures within 6 months of its market introduction. It's and its minor metabolites are the 2-phenyl 1,3-propanediol monocarbamate (MCF) and 3-carbamoyl 2-phenylpropanoic acid (CPPA). So it has been suggested that during the oxidative degradation of NCF to MCF to CPPA, the intermediate 3-carbamoyl 2-phenylpropanoldehyde could be converted to a potentially toxic reactive metabolite, which is your 2-phenylpropanol or atropaldehyde, and also isolation of 4-hydroxy-5-phenyl 1-deoxazaferhydroin 2, which is also toxic. Your placement of a fluorine atom at the carbon 2 position of felbamate resulted in a very potent anticonvulsant 2-fluorofelbamate that lacks the idiosyncratic properties of felbamate, and it is currently under phase 2 clinical trials. That's all for my part. I give the floor to
Okay, so
you.
moving on for the novel broad spectrum anticonvulsants, we have the lamotrigine, sold under the brand name Lamictal. So it is an anti-epileptic drug of the phenyltryazine class, and it has been found effective against refractory partial seizures. So everything that was mentioned here was given to us a while ago by the reporter while he discussed about the specific agents or with their corresponding mechanism of action. So for the mechanism of action, so it blocks the sodium channel so that is both voltage and use dependent, and also it inhibits the high threshold calcium channel, possibly through inhibition of presynaptic n-type calcium channels, and also it blocks the glutamate release. So lamotrigine is effective in a wide variety of seizure types, including the focal, the generalized absent seizures, and the Lennox-Gastaut syndrome. And also, it is used to treat bipolar disorder, and it is metabolized primarily to the 2N-glucuronide metabolite through the UGT1A4 pathway. And for the topiramate, so Topamax, and also for the lamotrigine, it should be reduced when adding valproate or valproic acid to therapy, and there must be slow titration to be observed, and it is necessary with lamotrigine when you add to it the valproic acid to a regimen that includes valproate in order to reduce or the risk of skin rashes, which may progress to a serious life-threatening reaction. And then for topiramate, under the brand name Topamax, so it is a sulfamate substituted monosaccharide, a derivative of the naturally occurring sugar D-fructose that exhibits broad and potent anti-epileptic drug actions at both glutamate and GABA receptors. So topiramate appears to block glutamate release, antagonize glutamate kynic acid AMPA receptors, and increase GABAergic transmission by binding to a site distinct from benzodiazepines or barbiturates on the GABA A receptor complex. So it was also mentioned earlier for the topiramate together with benzodiazepines and the barbiturates. So topiramate is effective for the use in partial and primarily generalized epilepsy, and also it is approved for the prevention of migraines, and it inhibits the CYP2C19, and it is induced by phenytoin and carbamazepine. So for zonisamide, with the brand name Zonegran and Exegran, so it is a sulfonamide type anticonvulsant approved for adjunctive therapy in the treatment of partial seizures in adults with epilepsy. So usually, um, the typical CNS adverse effects of zonisamide, it may cause kidney stones, and there's an oligohydrosis where there's a reduction in sweating. So the patient should be monitored from time to time for their increased body temperature and for the decreased sweating. So zonisamide is contraindicated in patients with sulfonamide or carbonic anhydrase inhibitor and hypersensitivity. And then for levetiracetam, under the brand name of Keppra, so levetiracetam is an analog of the nootropic agent piracetam. So unlike piracetam, lev does not have any affinity, and for the AMPA receptor, thereby has no nootropic activity for the treatment of Alzheimer's disease, modulating kainite, AMPA-induced excitatory synaptic currents, thus decreasing membrane conductance. So levetiracetam is approved for an adjunct therapy of focal onset, myoclonic, and primary generalized tonic-clonic seizures in adults and children. So the drug is really well absorbed orally, and they are usually excreted in urine, mostly unchanged. And then now let's proceed to the anticonvulsants that acts on a selective molecular target. So tiagabine, ethosuximide, methosuximide, and vigabatrin. So let's begin for the tiagabine. So tiagabine blocks GABA uptake as a major mode of its anticonvulsant activity. So also it was mentioned earlier about the what are the things that we have to know about tiagabine. So I think it's been clearly stated and well explained a while ago by my pair on what this drug about. So tiagabine is usually effective as an adjunctive treatment in partial onset seizures. And then for ethosuximide, under the brand name Zarantin, ethosuximide is considered the prototypical rather anticonvulsant needed for treating patients with absence seizures, and also for methosuximide. And then for vigabatrin, you have the Sabril. So still a while ago, it has been well explained what this thing all about, especially the Sabril. So my pair mentioned earlier that you need to reconstitute it since it comes in powder form. So it's a 4-vinyl analog of GABA, as it produces its pharmacological action by irreversibly blocking rather GABA catabolism catalyzed by GABA T. So it caused a reversible visual field defect associated with retinal function in the eyes. And then lastly would be the benzodiazepine. So there's only one benzodiazepine here. So we have the clonazepam, sold under the brand name Clonopine. So it is useful in absence seizures and in myoclonic seizures. And then the tolerance to the anticonvulsant effect of the clonazepam often developed rather quickly, and it is a common problem with the benzodiazepines. So I won't really dwell on this thing since a while ago it has been discussed and it has been furtherly elaborated by my pair. So that would be all for the clinically anticonvulsant agents, or clinically effective or important anticonvulsants rather. So now, as you can see here, a while ago we discussed about the different mechanisms of action of our drug products, of our anticonvulsants. So we have also the different drug targets. So we have our voltage gated sodium channel, our voltage gated or high voltage activated calcium channel, the AMPA and the NDMDA receptors, the T-type calcium 2 channel, and then the GAT1 and for the GABA A receptors. So here, as you can see that um, for the voltage gated sodium channels, so the ones that will block the activity of our voltage gated sodium channel would be the following drugs: carbamazepine, oxcarbazepine, lamotrigine, phenytoin, topiramate, valproic acid, and zonisamide. And the one that will block our voltage gated calcium channels would be, or the high voltage activated calcium channel, since you also have here the T-type calcium channel. So for the high voltage calcium channel, we have the lamotrigine, topiramate, gabapentin, and pregabalin. And also for the T-type calcium 2 channel, we have here the valproic acid and zonisamide. And for the GABA A receptor, the target would be the target receptor for the benzodiazepines and barbiturates would be the GABA A. And then here, the tiagabine, vigabatrin under a specific mechanism of action, the GABA T and the GAT1. So artopyramate, so here, artopyramate has also been shown to inhibit excitatory neurotransmission by blocking the AMPA receptors. So that would be our topiramate, AMPA receptors. So when we mention about AMPA, so it's more on the um it's more on the calcium, or like, yeah, it's more on the calcium or sodium. And then we also have the pregabalin and the gabapentin. So this one. And they also exert their effects by interacting with high voltage activated calcium channels. So our gabapentin and pregabalin bind to an accessory subunit of high voltage activated sodium channel called the alpha 2 delta 1, because the presynaptic channels that contain this specific subunit appear to modulate the release of excitatory neurotransmitter such as the glutamate. So this one. And also the inhibition of alpha 2 delta 1 containing calcium channels by gabapentin and the pregabalin is speculated to be one of the main reasons for their anti-epileptic effect. And lastly, for the another high voltage activated calcium channel blocker would be the levetiracetam. So levetiracetam is considered to be kanang unique siya. There's a unique um, mechanism of action wherein its ability to bind to the so-called SV2A na protein found in the walls of vesicles that contains glutamate. So SV2A, it contains glutamate. So the binding of your levetiracetam to this SV2A appears to impair the synaptic release of glutamate to here to your neurons, and thus it will decrease the neuronal hyperexcitability or excitability. So that would be all for this illustration, and I hope you understood it well. So now let's move on to the table that I have prepared just to summarize everything on its mechanism of action. So we have our carbamazepine. So its mechanism of action, it blocks sodium channels, and also I indicated the common side effects or uh, common side effects for that specific drug. So we have hyponatremia, of course, when you block sodium channels, so meaning there's on you don't permit the entry of uh, sodium ions, meaning so hyponatremia. So insufficient supply of sodium in our body. And then ethosuximide, it blocks calcium channels, so the patient will experience gastrointestinal upset and blood dyscrasias. And then valbamate, so there's a multiple mechanism of action. So as you can see here, we have valbamate here, and then usually the side effects would be the liver toxicity and aplastic anemia. And then you have the gabapentin, it's unknown. So although it's been specified a while ago, but not really, we can't really tell that that's the exact mechanism of action of our gabapentin. And then side effects would include weight gain. Lamotrigine, it has also a multiple mechanism of action. So as you can see here, you have here the lamotrigine and this one lamotrigine. So you have it blocks voltage-gated sodium and also it blocks the voltage-gated calcium channels. And then levetiracetam, it has also a multiple mechanism of action. Side effects is anorexia. Oxcarbazepine, it blocks sodium channels. Hyponatremia still. Phenytoin, it blocks sodium channels. Diplopia, and then diplopia meaning there's an kanang dual vision, murag duplicated na vision. So when you look at things, it's kanang doubled ba, murag duha mo makita. And then gingival hyperplasia, and then hirsutism. So when you say it hirsutism, meaning there's an excessive hair growth in the body. And then gingival hyperplasia kay kanang ang teeth kay murag so something like that, more on the um teeth part, more on that. And then pregabalin, still there's a multiple mechanism of action. Weight gain. Tiagabin, it blocks the GABA uptake, so it has been explained a while ago. Also weight gain. Topiramate, multiple mechanism of action, so there's a cognitive complaints, weight loss. And then valproic acid, multiple mechanism of action, also weight gain. The side effects, vigabatrin, irreversible binding of GABA-T. And then side effects include vision loss. Zonisamide, there's a multiple mechanism of action. Stale cognitive complaints. Benzodiazepines, it binds to GABA-A receptor. And then insomnia. And then lastly would be the barbiturate. Still, it would bind to our GABA-A receptor and it will induce an effect of drowsiness. Although majority of the anticonvulsants would give us the side effects of drowsiness, but yeah, common side effect really of barbiturates would include or would be drowsiness. Now let's proceed to the therapeutic indications for anticonvulsant agents. So here I am. It's not. It can't be seen in our reference book in chemistry, but I've included it here since I've I've got this from our pharmacology book, in which it summarizes or in which it discusses on the this kind of drug and what will happen if it won't, if still the seizures will persist, and what will happen if it still persists. The simple, like something like that. And then now let's begin for the focal epilepsy. So focal epilepsy, so you have the simple partial seizures. So simple partial, complex partial, with or without secondary generalizations. Okay, usually I wasn't able to mention earlier that when you have a partial um, simple partial seizures or complex partial seizures, there will always a greater possibility of developing or progressing it into the generalized tonic-clonic seizures. So, all it can when you experience simple partial seizures, like don't think that it will just stop there, or when you don't find any interventions or anything that would help you get through it, because it will eventually progress into something more severe or more serious conditions. So now, so let's consider it first based on patient characteristics, diagnosis, and symptoms, and concurrent medical problems. So usually um, when we consider this thing, so usually we give lamotrigine, levetiracetam, and topiramate. And consider next if the seizures persist or adverse effects of first drug limit therapy. So if still the seizures persist or there's an adverse reaction of the first drug limit therapy, then you can use carbamazepine, lacosamide, pregabalin, and zonisamide. And if it still persists, so let's say for example this would be our last resort. So let's consider it as an alternative if seizures persist or adverse effects limit therapy. So when you say adverse effects limit therapy, we can give this drug to all patients since we have different patients, man. We have children, we have elderly, and then we have adults, so different man. So each of them have their own different kanang reactions in the body. So meaning if they have this certain adverse effects on that certain type of person, then the therapy would be limited only. So if that would happen, then consider this still as an alternative. So you have divalproex. So divalproex is a combination of sodium valproate and valproic acid. So we have gabapentin, oxcarbazepine, phenytoin, and tiagapine. So you can use that as an alternative if still the seizures persist. And okay, later na lang. And then for elderly patients, you can use lamotrigine, gabapentin, lamotrigine, and then if still seizures persist, then you can use gabapentin, and then if it still persists, then you can take now the carbamazepine. And then now let's move on to primary generalized epilepsy. So for absent seizures, you can use divalproex and lamotrigine, and then if it persists, and then ethosuximide, levetiracetam, topiramate, and zonisamide for the alternative. For myoclonic, you have your first line treatment, divalproex and levetiracetam. Sorry for the wrong spelling. And then if it still persists, lamotrigine, topiramate, and then last resort would be benzodiazepines and zonisamide. Also have here the tonic-clonic, give lamotrigine, levetiracetam, topiramate, and then divalproex or zonisamide. And then it is not indicated here what would be the last resort or the alternative if still the seizure would persist. So by that time, you can talk again to your doctor. So what would be the suggested interventions for this matter? And then lastly would be status epilepticus. So it has been discussed earlier by my pair that it is the status epilepticus is consists of two or more seizure occur without recovery of full consciousness in between episodes. So usually status epilepticus characterized by a seizure that lasts for 5 minutes. So that would be so serious and really needs an immediate response. So you can give the patient benzodiazepines, primarily diazepam and lorazepam, and phospheniton. And then you can also consider next if seizures persist or adverse effects of first drug limit therapy, you can give barbiturates. Okay, and then here, also I indicated the different inhibitors and inducers. We have CYP1A1 on 1A2 carbamazepine, CYP2C8 for carbamazepine, CYP2C9. So they have different actions. It can be an inducer and it can be an inhibitor, enzyme inducer and enzyme inhibitor. Let's say, for example, carbamazepine is an enzyme inducer, and then but also it acts differently on other enzyme. So 2C8, carbamazepine, CYP2C9, it either they will inhibit or they will induce this specific um, enzyme. And then yeah, it goes like there. Clobazam, divalproex, fulvamate, phenobarbital, phenytoin, zonisamide, CYP3A4, you have carbamazepine, clobazam, etosuximide, perampanel, tiagabine, zonisamide, and then UDP, glucuronyl transferase, you have divalproex, zogabine, lamotrigine, and lorazepam. So that would be all for our report about anticonvulsants. But usually anticonvulsants kanang when let's say for example, let's consider this for pregnant, okay, women's health and epilepsy. So for pregnant women, you don't really give anticonvulsants immediately, or you really need to monitor, you really need to assess and evaluate the patient's well-being first, since kanang kuan danger, let's say for example, dangerous man ang effect sa epileptic drug, sorry, sa mga um, kanang pregnant women, and also to those people who are planning to get pregnant, or to those women na who are taking kanang mga contraceptives. So all women considered to be pregnant should take a should be on high folic acid, usually 1 to 5 milligram of folic acid would be taken prior to contraception. And divalproex and barbiturates should be, or as much as possible, they should be avoided. And then also, it is very important that you consider the welfare of the mother before giving the anti-epileptic drugs, as not to impose harm to the mother itself and also to the baby. So, what would be other information that we could give? How about Isaiah? Do you have anything to share or to add on the information?
Wala na.
Okay.
Nothing.
Okay. So that would be all for our presentation on anticonvulsants, and I hope that we discussed everything clear, and we elaborated things here, and we apologize if there are any technical difficulties during the presentation. So thank you so much for listening, and have a great day. Isaiah, okay na? Isaiah. Hello?
Stop na ako.
Yep.